Hi guys, and welcome to DermpathTalk. With us today is Dr. James Ramirez, a dermatopathologist at St. Joseph Mercy in Ann Arbor, Michigan. Dr. Ramirez, welcome, and thank you so much for accepting the invitation.
Thank you for having me. This is an interesting biopsy because it's something that you should always keep in the back of your mind, always be aware of, and something you don't want to miss, but can be pretty easy to miss because it can mimic a lot of things. So here we have a biopsy which shows basically not a whole lot with the exception of maybe a little bit areas of here of spongiosis where the arrow's pointing. You see some intercellular edema, some spaces right there. That's fluid that's collecting within the epidermis. And we also have areas where it's hard to tell at this power, but areas here and areas here, which if we zoom in on those areas, we can see that they're actually intraepidermal micropustules, or they are little collections of neutrophils. Here's one over here. And this is situated within the granular layer. And here's one over here, which may actually be situated around a follicle. So in this kind of situation, you may think of a few things. You may think of, with the neutrophils, you may think of a psoriasis type of pattern. There is maybe a slight amount of psoriasiform acanthosis here. But another thing I'd like to think about and more easily categorize this thing is into one of these spongiotic disorders, and in particular, into the neutrophilic spongiosis. And once you've done that, you can kind of narrow it down to a few entities, one of which is what we spoke a little bit about already, psoriasis, and psoriasis-related conditions such as acute generalized xanthomatous pustulosis, and a few other things. The big thing is fungal infections or dermatophyte or candidosis. And then third on the list, maybe things like immunobolus, unusual things like IgA pemphigus. So in this case, if we zoom in a little bit more, this actually turned out to be a case of a dermatophyte infection. You can see a few more over here. So it's a nice mimicker of psoriasis, and this is true with what we're taught in residency. Anytime you see neutrophils within the epidermis, always think about dermatophyte, always think about Candida, and always think about getting your special stains, your PAS. In this case, you don't really need it because you can actually see the little bugs right there and right there. And a good clue is often to look for in areas where there's basket weave or hyperorthokeratosis as opposed to parakeratosis. They tend to like to live in the areas of hyperorthokeratosis. But just to be safe, we did a PAS stain, and here we can see the dermatophyte right again in the areas of hyperkeratosis near the pustules. There may be even a few organisms in the pustule itself. If we look really close, we can see the septated hyphae right here, identifying them as Candida. So this is a nice reminder. If you see those neutrophils within the epidermis, you can think about dermatophyte, think about those things we just spoke about, and it should help you to catch this thing and hopefully you won't miss it again or ever miss it in the future. Thanks.
Thank you, Dr. Ramirez. Could you highlight for us some of the most important clues to get to diagnosis in this case?
Yeah, sure. I think the biggest one is the one that you can see right here and here. Anytime you see the neutrophils within the epidermis, that's always a clue. But they do talk about dermatophyte as being one of the great inflammatory mimickers. So I think that anytime that you see something that's just not making sense and it's a rash or comes labeled as a rash and doesn't quite fit into anything, it's always a good idea to do a PAS stain. And the third thing actually is whenever I see any time in the clinical history a description of ring-like or annular, or even if they don't explicitly say that, but they may be describing things like subacute cutaneous lupus erythematosus, you know that the clinician is probably seeing an annular lesion. In those cases, you might lower your threshold to order a PAS stain, but always keep it in the back of your mind. If something's just not making sense, you may want to go ahead and do a PAS stain and hopefully catch the critter.
Could we distinguish between Candida and dermatophyte?
Yeah, you can actually. In nails, it's most often where we see it actually. In nails, Candida is classically described as having yeast and pseudohyphae. I don't have a picture of it, but it's not going to have the same kind of what's described as a boxcar look for dermatophyte infection. They really look kind of very sort of rectangular in appearance, whereas the pseudo-hyphae in Candida can look a little bit like these boxcars, but they have more of a pinched or rounded look to it. So that's really the difference. And of course, if you see free-floating yeast organisms, and that's better for Candida, of course.
Thank you so much, Dr. Ramirez, and thank you guys, and hope to talk to you again in another edition of DermpathTalk.